and Ashok Raju, Pachori sir, other colleagues will be joining now, Arun Khanna and everybody. So this is basically for the F&B and DNB students and fellows across the country. We need young surgeons like you to highlight on the principles and the basics. So we'll start over to Vaibhav. You can go ahead with the biomechanics of knee.
So thank you, Ashok. Thank you, sir, for giving me us an opportunity. I think it's an important thing, and the topic that is given
Young
to me is
surgeons like you
biomechanics of the
to
knee. As they say, as is our biomechanics, so is our orthopedics, and I think that's true for arthroplasty as well. I'll be going very basics. Many of the things that you may already be knowing, so it's just a revision of what you may be knowing. So we all know that the knee is a mechanism of three joints and four bones: the femur, the tibia, the patella, and the fibula. It interacts as two separate joints: the tibiofemoral and the patellofemoral joint. And the function of these two joints is to allow certain movement, restrict others, and basically provide a load transfer through the lower limb. So while we call knee as a joint, there are two functional joints: the tibiofemoral joint, which have the articulation for flexion, extension, rotation, and load transfer, and patellofemoral joint, which is responsible for governing the extensor mechanism efficiency. So in today's talk, we'll talk about the tibiofemoral joint, the rotations, the translation, and the screw home mechanism, the axial and rotational alignment of the knee, the patellofemoral joint, the joint forces, and the biomechanics of the ligaments in the knee. So when we look at the rotation and translation, we must know that there are two types of movement that are happening. One is the axial movement and the other is the translatory movement. So in flexion extension R, the knee moves through 0 to 135 degree of the movement. It allows some degree of varus and valgus, which is 6 to 8 degree in extension. And then there is a rotational component which is often overlooked, which is around 25 to 30 degree in the flexion. At the same time, the knee has some amount of translatory movement, which in anteroposterior direction is around 5 to 10 millimeter. In compression, distraction, it is around 2 to 5 millimeter, and a mediolateral opening, which is around 1 to 2 millimeters. Remember that the rotations are expressed in degrees about 3 cardinal axes, whereas translation describes a linear displacement of the tibia relative to the femur. So these are the movement that you see. This is the axis. You'll see all the 6 degree of freedom, and you will also see that the movement alters this flexion, extension, adduction, abduction, and rotation changes in the different gait cycle with different type of rotation and combination of rotation leading to a normal gait. And why is that important? Because all of that, when as an arthroplasty surgeon, we change the normal biomechanics, and every aspect of the movement impacts every other aspect, and hence the gait pattern is now one of the key focus when we look at patient satisfaction after knee arthroplasty. We also know that there is a concept of instant center of motion, and that the flexion axis varies in a helical fashion in normal knee. So there is an average of 2 millimeter posterior translation of the medial femoral condyle, and this is in contrast to on what's happening on the lateral side, where the translation may be up to 21 millimeter. So you'll see that there is a center of motion different for the medial and the lateral side, and all of this has a relevance in the posterior rollback. As the knee flexes, the instant center of rotation of the femur moves posteriorly. So you look, that is how the center of motion is changing in a helical fashion from 0 to 120 degree of arc of the motion. Another concept that we must know is a femoral rollback, which means that there is a posterior translation of the femoral condyle on the tibial plateau during flexion, and it allows for increased knee flexion by avoiding impingement. So unless there is a rollback, the knee will impinge, and that's a crucial concept. And today when we talk about different kind of implant, one of the key element is preserving rollback in the implant designing so as to achieve a deep flexion and preventing the anterior femoral impingement on the tibial spine. So this is very important to get a good range in the patient, that any implant design or any surgical technique must help us get a femoral rollback. So this is how the contact point change with the rollback, and this is a very important concept when we look at our arthroplasty, whether it is replaced or it is a normal knee. The next concept as a student that we must know is a screw home mechanism. So if you look at what happens in extension and flexion, in extension there is an external rotation of the tibia on the femur during the extension, and there is an internal rotation of the tibia during knee flexion. Why that does happen? Because there is a medially based pivoting. That means that the medial tibial plateau surface is longer than the lateral tibial plateau, enabling the locking of the knee, decreasing the work performed by the quadricep while standing. So it's an important concept that everyone must know. So this is how it happens. So you'll see that the medial surface pivots in the concave tibial plateau. It's an important concept because, again, if we can replicate this in an arthroplasty, the patient satisfaction is quite different. Now we'll talk about a lot of alignment, but I think two concepts that one must know or understand is the mechanical axis and the anatomical axis. The anatomical axis of the femur and tibia form a valgus angle of 6 plus minus 2 degrees, and the tibial articular surface is around 3 degree of varus relative to the mechanical axis, and the femoral articular surface is around 9 degree valgus. I think we'll talk much more in the alignment concepts in future talks, but this is a simple concept that everyone must understand and know. So this is the diagram in which one can see how the mechanical alignment versus the anatomical alignment of the femur varies. Now coming to the other joint, which is the patellofemoral joint, which is basically a sliding articulation. One must remember two numbers, that the patella moves 7 centimeter caudally during full flexion, and the maximum contact between the femur and the patella happen at the 45 degree of flexion. We all know that the primary function of patella is to increase the lever arm of the extensor mechanism around the knee, and this ensures an efficient quadricep contraction. This lever arm is important because this is greatest at 20 degree of flexion, and the quadricep force required for knee extension increases significantly in the last 20 degree of extension. These are the two key concepts that one must know regarding the patella. This is how it feels, and you can see how the excursion changes, and it's very important again for a patient satisfaction once you are doing an arthroplasty, remembering how the excursion of patella is happening, where is the contact point, how it is shape matching to the trochlea. We also must know what are the key stabilizers in an unarthroplasty joints, in non-resurfaced joints, so which is medial patellofemoral ligament that constitute 60% of the primary passive restraint to the lateral translation, and this happens maximally at the 20 degree of knee flexion. The other contributing structures are, of course, the lateral retinaculum and the medial patellomeniscal ligament. The dynamic restraint, however, remains the quadricep muscle, which contributes to the active stabilization of patella throughout the arc of the motion. This is the structure that you can see. The MPFL is clearly visible. So if you're using a medial parapatellar approach or even the other approaches, this is the structure which is not there. So our stability has to be implant driven, and also where necessary, also strengthened by the soft tissues. Another important concept when you're talking about the knee biomechanics is the Q angle. The angle is the angle between the extended anatomical axis of the femur and the line between the center of patella and the tibial tubercle. For males and females, it is different. It's around 13 degree in males during flexion and 18 degree for females in flexion, and it's roughly around 8 degree in extension. One other thing that we must know are how are the forces on the joint. So the forces vary in different phases of the gait. So while standing on both feet transmits the normal body weight, swing phase has half the body weight, a unilateral stance phase is 2 to 4 times the body weight, and the jogging is around 6 times of the body weight. So it's different at different angles and different phases of the gait cycle. Similarly, the patellofemoral joint loading again is different while walking, ascending, descending, and squatting. So the maximum amount of the patellofemoral force happens once the person is squatting on the floor. The other things that one must know about the knee biomechanics is the biomechanics of the ACL. The ACL prevents the anterior tibial displacement on the femur and also prevents the hyperextension varus and valgus stress. The least stress on the ACL is between 30 to 60 degree of flexion. Remember that the ACL has two bundles, the anteromedial and posterolateral. The anteromedial is tight in flexion and extension, whereas posterolateral is only tight in extension. It's a key concept because it helps understand how the inherent stability of the replaced joint is. PCL, again, I think one of the key focus today is how the PCL can be retained, and with the medial pivot knees, whether and what portion of PCL needs to be excised. So remember, again, the PCL has two bundles, the anterolateral and posteromedial. The anterolateral is taut in flexion, whereas posteromedial is taut in extension. See, so the posteromedial fiber become much more in tension when the knee approaches the full extension, and the anterolateral becomes more when knee moves into flexion. So depending on which of those are tight and where the tightness reside, you may do a partial resection of PCL even when you're doing a CR or a medial pivot joint. So in the end, the key takeaways is that the knee basically are two joints, the tibiofemoral and the patellofemoral joint. The screw home mechanism and femoral rollback are critical for understanding efficient extension and deep flexion of the knee. I think these are two critical concepts that one must understand. The alignment, we'll talk more about it in detail. Mechanical, anatomical, kinematic governs the load distribution. The patella magnifies the extensor efficiency, and the MPFL is the primary lateral restraint. The joint forces are different for different activities, and activities like jogging and squatting result in high joint forces. And we must remember that the joint is not mainly the bones, but important are the ligaments as well. The two key ligaments are ACL and PCL, and they prevent the tibial translation in anterior and posterior direction. So these are the key takeaways and basics in a nutshell of knee biomechanics that one must know to be a good arthroplasty surgeon. So I thank you for attention, and if there are any questions, I'm happy to take them.
Yeah, thanks, Vaibhav, for the detail and the basic things what every orthoplastic surgeon should know before practicing any alignment strategies around the knee. Thanks, Vaibhav. So I think it's anything you can reply in the chat box, Vaibhav. So over to Suhas.
Thank you. Thank you, Ashok.
Yeah.
Vaibhav,
Yes.
Yes, sir.
before Suhas takes over, this how you practically suggest, like if somebody asks you, would you say not to do jogging and not to do treadmill when you early this biomechanical principle, do you implement in your actual practice?
So, sir, normally it's always the risk and reward ratio. So, if the benefit of an activity is more than the detrimental effect, then you have to always go for that activity. For example, if someone has already a pre-existing patellofemoral joint arthritis, then I would suggest them to avoid squatting and doing activity that increases the load. But in absence of any concrete evidence of chondromalacia or a cartilage damage, I would actually encourage them to do the activity to maintain the motion and the strength. So it's a trade-off. So once the arthritis sets in, or if someone is predisposed to a particular thing, the activity that affect that particular compartment should be avoided. But in absence of any of those symptoms, it is okay for them to proceed.
Thank you, Vaibhav. Yeah.
Sir wants to say something. I think he's muted. Sir,
You're muted, sir.
No, bye. Thank you.
Yeah.
Suhas, you're there? Yeah.
Yeah, I'm there. Can I start?
Yes, sir. Yeah. You can go ahead.
You're able to see my screen?
Yes, perfect. Yeah.
Okay. Good evening, everyone. I would like to thank the education chair as well as the committee for onboarding me for this particular talk. My topic is alignment techniques in TKA, specifically referring to the 3 alignment strategies that I've mentioned here. And I've added the word personalization is because you've heard so much about the anatomical aspect, the biomechanical aspect of the knee from Dr. Bagaria. And here is where you apply all those concepts. So let's move on with the talk. So this is Dr. Hirschman, and I visited him last year, and I had a great time with him. And he, in one of his talks, the question was, what is knee phenotype? So unless you understand the phenotype, you cannot recreate it, right? But he gave a very different definition from what I usually thought a phenotype is. He said a knee phenotype is not just about alignment. He said it is about bony alignment for that particular patient, native soft tissue laxity, the kinematics with which the knee actually functions, the morphology, which is the anatomy, and the biology, which is the ligaments and all the other mechanisms Dr. Bagaria spoke about. So if you want to aspire and recreate a personalized anatomic joint, you need to recreate all the 5 aspects of a knee phenotype. And for this particular talk, we are only talking about bony alignment. But please be sure that just by recreating the bony anatomy, you're not recreating the whole personalized arthroplasty aspect of a total knee replacement. When it comes to alignment, I think we've done ourselves a lot of disservice by describing multiple alignment strategies. But if you closely look between them, there is hardly any differentiation. That is the reason there is a lot of confusion between one strategy to the other, because they are very nuanced. Having practiced most of these strategies in the last 5 years, and with the backing of most faculty here on this panel, I can safely say that there are only 3 alignment strategies that you need to know and you need to practice. And if you do these 3 alignment strategies, you will be able to do 100% of your knees. So hence, we will only concentrate on these 3, and the rest of the strategies are actually a amalgamation or an offshoot of these 3 fundamental philosophies that I'm going to talk about. Let us start with mechanical alignment, which is almost like the OG of total knee replacement. It was evolved in the 1970s and still widely practiced even today. At that point in time, Dr. Insal as well as Dr. Ranawat gave us 2 tenets for mechanical alignment. They said, cut your tibia at 90 degrees, cut your femur at 90 degrees, make sure your HK axis is 180 degrees, or in popular terms, 0, 0, 0. That means you have to give your knee, hip, and ankle an absolute straight line. And what was the goal then? To have pain relief and to extend the implant survivorship. We all know that at that particular point, the polyethylene, the engineering of the implants, and the instrumentations were far from ideal. And hence, their goal was much simpler. So though this was away from the anatomic alignment philosophy which Hungerford gave, where he prescribed that you recreate the native anatomy of that particular patient, the mechanical alignment strategy reigned supreme because that was surviving much better as compared to the anatomic alignment. So what does mechanical alignment involve? First and foremost is it is the same target for every particular knee. You cut the femur at 90 degrees to the axis, you cut the tibia at 90 degrees to the axis, you attain a neutral HKA in that particular patient, and this has done well for the last 4 decades. You're trying to achieve equal gaps as well as equal compartment load both on the medial and the lateral side. And you have to acknowledge the fact that for the last 4 decades, consistent results of up to 90 to 95% at 15 years have been delivered across all the surgeons or regions where this has been practicing. But what exactly happens in mechanical alignment? If you see this particular diagram, you can see that the anatomic femur is in valgus. But instead of valgus, if you cut this knee at neutral, you're distalizing the lateral joint line. If you're cutting the tibia in neutral instead of varus, you're actually elevating the medial joint line. You will end up causing medial tightness both in flexion as well as extension, and this will actually force you to do mandatory releases both in flexion and extension, as well as external rotation of the femur in order to open up the flexion gap. And great books were written on how soft tissue balancing needs to be done. But you need to bear in mind that by doing this, you might achieve equal gaps, but you're changing the joint line obliquity, you're changing the constitutional varus to neutral in every single patient. So at the end of the day, you're changing anatomy, you're changing laxity pattern, and you're changing the kinematics of this particular patient. But if as a surgeon, if this is what you want to do, and if you feel you have excellent results in your patients, there is no need to change your philosophy. Having said that, this is something which can be done usually with all conventional instrumentations, and it is freely available. But if you acknowledge the fact that you're changing all these 3 or 4 parameters which I mentioned earlier, which are required for personalized arthroplasty, you can do a very good analysis of this from this particular paper by Ventitoli, where he's given us flaws of mechanical alignment. And I recently heard that there is a new paper, 10 flaws of kinematic alignment also, which I haven't read, but I'll surely do it in probably in the next 1 or 2 weeks. So if you don't accept the concept of mechanical alignment strategy, where you're changing the anatomy, biomechanics, and philosophy, you need to come to kinematic alignment, which is the exact opposite of mechanical alignment. Here you can see that there are 3 lines that you can see: the green, the yellow, as well as the purple. I will describe these axes in the next picture, but you need to understand that these lines on the femur are parallel to each other or perpendicular to each other. And more importantly, they are either parallel or perpendicular to the joint line itself. So using these 3 axes, Stephen Howell came up with the working hypothesis that if I recreate the surface of the femur exactly what it was, I would by default recreate all these 3 axes. So this was his working hypothesis, and that is how he came up with the concept of kinematic alignment, where you have the Akoff axis where the tibia moves over the femur. You have the Coughlin axis where the patella moves in the group, inflection and extension. And you have the Freeman-Prinskarova axis where you have the internal external rotation of the tibia on the femur. So he said, if I know the thickness of the implant, the one that I'm using, and I exactly remove the same amount of bone from both the distal aspect as well as the posterior aspect, I would recreate the shape of the femur. And if I recreate the shape of the femur, I would be parallel and perpendicular to the 3 axes that I have described. Hence, I would recreate the biomechanics of the knee. So this is the core fundamental philosophy of kinematic alignment strategy. And then he gave 2 exceptions to that. That means recreating femur is non-negotiable, number 1. But at the end, if you have some native laxity and you need to make adjustments, you can make it only on the tibia. So if somebody is doing kinematic alignment and not recreating the shape of the femur, then he is not practicing kinematic alignment. If you couple medial pivot knee with a large prosthetic trochlea femur, this is the best combination for you to practice kinematic alignment strategy. Having said that, this is a case example, an extreme case which was taken deliberately. You can see that I've planned with equal cuts in the distal posterior aspect as well as tibia. But here you can see I'm end up giving 7.5 varus on the tibia, 5 valgus on the femur, and 1 degree internal rotation. So if I'm a purist, a KA guy, I would go ahead and do this without hesitation. So just for the sake of capturing the gaps, you can see that I've captured gaps in this extreme position of 7.5 varus, and you can see that I'm getting absolutely perfect gaps. So all that I had to do in this particular patient, if I'm doing a KA plan, is just raise the tibia, get my gaps down to 18, and I'm done. But this is where the hesitation comes from most surgeons, because they're worried about a tibia surviving at 8 degrees of varus. Hence, the hesitation for kinematic alignment is extreme position of the implants, putting varus as well as slope, internally rotating the femur to cut equal components. And hence, will these implants survive? Will the patella track well? And so many of these concerns. But to give credit to the KA guys, over the last 10 years, we've had 13-year outcomes, 17-year outcomes. I think Dr. Vikram will talk about it, that these implants in these positions have survived. Now it matters, now it comes to the matter of functional outcome, which probably we can debate later. So kinematic alignment is where you have unrestricted boundaries. You will just recreate the shape of the femur. You accept native laxity, and whatever adjustments you want to make, you will only make on the tibia, and you will keep the femur absolutely constant. But if this is something that you don't want to do, you're concerned about the amount of varus you're giving, the amount of internal rotation you're giving, functional alignment is the best of both worlds. This is where the target is flipped. In kinematic alignment, alignment is constant, gaps are flexible. In functional alignment, gaps are constant. That means your target is the gap. At the end of the day, whatever alignment you get by balancing the gaps, you accept that alignment strategy. So it's a matter of which comes first, number one. Number two, kinematic alignment can be done with normal instrumentation, but functional alignment can only be done with technology, just like CAS or robotics. So here is a case where you can see on the right part of the screen, I have all different numbers. And here, because it is functional alignment, I have full freedom in moving the position of the implant, both femur and tibia, in all the 6 axes. And my goal is only to get these numbers to 18 as far as the triathlon is concerned. So you can see I'm raising my tibia, I'm dislicing my femur, I'm giving varus on the tibia, I'm externally rotating my femur, but I'm doing this in order to get the gaps to 18. At the end of 18, whatever I get, varus I get on the femur, whatever external rotation and valgus I get on the tibia, on the femur, I'm accepting. So you're actually flipping the whole concept. So K, guys, alignment is non-negotiable. Femur has to be absolutely resurfaced. You have some wiggle room for the tibia, and whatever resultant balance you get, you accept. But in functional alignment, it is the reverse. Balance is the driving force. You will balance the knee and accept whatever native alignment you get, but within the boundaries which is acceptable to you as a surgeon. So functional alignment, you can move both femur and tibia in favor of balance, and you accept whatever alignment you get. So this is the whole alignment spectrum, with mechanical alignment, which is 0, 0, 0 on one side, kinematic alignment, where you're reshaping the femur, and functional alignment is midway between both, where you're trying to achieve best of both worlds. So kinematic alignment is unrestricted, native laxity is acceptable, you will only move the tibia. Mechanical alignment is 0, 0, 0. You can move, and you will actually move the femur and tibia, and your axis has to be 180 degrees. Plus minus 2, I put that because you can have an error of a degree or so. Functional alignment has boundaries, but balance is the key, and you can both move femur as well as the tibia. So these are the 3 alignment concepts, and this is just a brief idea for you to understand the concept. Now, once you understand and you start practicing, that is only when you will really get a grip of each of these alignment strategies. Thank you.
Thanks, Suhas, for this detailed briefing of all the 3 alignments. And so over to Dr. Hemant, sir. Good evening.
Hi, good evening. Right, lovely. I think it's a great start. And my brief, shall I start sharing, or we're going to have some question and answers?
No, you can go ahead, sir. Yeah.
Yeah. See, although my title says video, I thought there are a lot of concepts and a lot of things that I can explain by pictures rather than video. I have some videos. If we have time, we can, show it at the end. But so let me start with my presentation. So can you see my screen?
Yes, sir. We can see your screen, sir. Yeah.
Lovely. Let me.
Any questions to Suhas? Anybody wants to ask him?
There is one question box.
Right. So we okay to go? Or any questions to be taken before that?
Yeah, Vikas can answer this chat box. Vikas can answer the chat box, and you can go ahead with the presentation. Yeah.
All right. Okay. See, so I think this is a eternal kind of debate in most conferences today on knee arthroplasty, and this debate, I think today ending up to be like somebody who's been in business for maybe say 20 years plus, and somebody who's come into business say maybe 5 or 10 years back. And these are new concepts that are evolving, new concepts that are coming up. And I, for one, have absolutely no problems in accepting the new concepts so long as they appeal and they become logical to me. So my brief is to talk on mechanical alignment, although I would say that I'm not a purist. And today, if I'm using technology, I'm going for functional, just exactly as was described by Suhas a few minutes earlier. So when I'm using technology, I'm actually going for functional. But when I'm using conventional surgery, when I'm going for mechanical. And I'm just going to tell you the details of how I balance my knees, with the mechanical as an aim, and possibly ending up as, what is called as adjusted mechanical. And no apologies for that. So, as we heard earlier from Vaibhav, it's a normal knee kinematics is the interplay. And the bottom line, I think, today is that TKR is attempting but cannot entirely reproduce the normal kinematics. So, I think anybody who is following knee, kinematic alignment cannot say that he is actually getting all entire knee kinematics reproduced, because there's no way you can reproduce that posterior posterolateral femoral sliding off that happens normally. So there's just no way that you can say that you are entirely reproducing the normal kinematics. This is the evolution that we heard earlier. There are a lot of other things, and as Suhas rightly said, there are only MA, KA, and FA that we are talking about today. Why did it all start? It started all with patient satisfaction, and there are, with the papers, especially from Bob Bone, he's talked about 20% dissatisfaction. There are some other patients that talked about dissatisfied, patients after knee replacements. I think the bottom line is that if this is the graphical representation of the knee with the hip center, alignment, limb alignment going through the center of the hip to the center of the ankle and passing through the knee at some point of time. This is, as you can easily see on the long leg scanogram. And TKR basically is a simple surgery where you're doing a distal femoral cut, you're doing a proximal tibial cut, and you are having a medial and lateral balance or imbalance, as it might be, as you heard earlier. So the bottom line is neutral alignment is actually reproducible, or aiming for neutral alignment, you go closer to the neutral alignment. But native knees are definitely not neutral, that we have already heard earlier. So it started with John Insull. This is how he started. He basically wanted to protect the components, and that is how it was, because he was trying to protect the all poly IB1 that was introduced, and later on IB2 that came about, that was having metal backing on the tibial side. So bottom line, it has to be historically, you will see hundreds and hundreds of papers talking about neutral mechanical axis as the gold standard. And the reason why they are talking about it being gold standard is that many failures are seen with some degree of varus in the tibia. And you can say that this is historical. This patient of mine failed at about 6 to 8 years or time. And that was because of some degree of tibial varus. Now, the same prosthesis I have seen surviving for 20 years plus. I have had 22 years and 24-year follow-up patients coming to me with the same prosthesis that is here. But this knee failed at about 6 to 8 years, and that I believe was because of some degree of virus. So TKR failures with outliers we have seen. Again, these are historical papers. Today's implants possibly are far better. The materials are far better, and they will possibly survive far longer as well. So whether you should have a fixed alignment approach for all patients or should you go for individual alignment strategy is something that a surgeon has to take a note of. And I think the important aspect is that we have heard a talk on kinematics that is actually doing the surgery without the use of technology. But I believe that the use of technology is mandatory for alternative alignment strategies, because you can be absolutely sure what degree of virus you are ending up in. Is the availability of technology. And I think it's important, especially in India, to differentiate patients who are significantly deformed. And my cutoff usually tends to be, say, 15 degrees or more of deformity in varus or valgus. I do not believe that you can actually, go for these kinematics, because there is just no way that you can, decipher what the pre-arthritic kinematics of the knee or alignment had been. So if you're doing a knee replacement for this kind of patient who's coming up, that's fine. You can certainly talk about tweaking the inclination, tweaking the alignment, and using kinematic balancing. But if you're talking about this patient, and this patient comes to you with this degree of deformity, this is almost 25 degrees of virus. And to work out what was the pre-arthritic kinematics in this patient, I think you are asking for a lot. And this is the kind of axis. And it's the same is true with the valgus alignment as well. So it needs a lot of imagination. If you have to assume that this knee had a certain degree of kinematics, or what was the original kinematic axis of these patients before the arthritis set in. So I'll come back to this image again, because I simplify the knee replacement surgery in 3 parts. One is the distal femur cut, that you are basically looking at the long leg scanograms. Proximal tibial cut, upper tibia cut, that is looking at the long axis of the tibia. and then you will be balancing that. Somebody who does not have the technology today, I think most people have facility to get long leg scanograms, but if you don't have that, you can even use a long X-ray film and look at this image and look at this, because this is the angle that we talk about when you're talking about distal femoral cut. This is the angle that we set on our jigs. So, and this is the tibial axis that we're talking about. So what I'm going to do now is I'm going to show you a typical varus knee, which is say more than 15 degrees, and how I do my mechanical alignment for these particular patients. Aim is to obviously get the balancing right, gap balancing right. So I'm going to talk about severe varus patient, and most of these patients you should keep a constraint option available. The system I use is anterior referencing, all the time, and I try to balance my extension gap first. As I start my surgery, I look at what is the amount of correction of the varus possible. So this determines actually how much of release of soft tissues that may be required right in the beginning. So I look at my intermedullary jig, and it is taken at the entry point is on the right side line, 1 inch from the top of the PCL fibers. And you can set whatever angle that you choose. Now, I believe that if you have to use a kinematic alignment in this patient, you would possibly end up putting a 8 or 9 degrees of valgus cut on this femur. So I've never done that in my life. I'm flabbergasted if I have to ever do that. So my typical cut is 5 degrees, and I can have variations depending on how the long leg scanogram looks like. So that angle between the mechanical axis and anatomical axis of the femur is what I consider. On an average, most of the times it is the 5 degrees valgus angle that I set here. And I'm then taking my cut using a 1.2 millimeter thick saw blade. I use it, take it flush with the distal face of the saw blade, and then I always measure my cuts because I need to see what kind of, how much resection I have. Now, in a typical varus knee, you may actually, depending on obviously the type, but majority of the times the jig is actually touching the lateral femoral condyle and not touching the medial femoral condyle off maybe by a millimeter or so. So my distal femoral thickness, component thickness is about 9 millimeters. So I am aiming to cut 8 or 9 millimeters here. And that is what I aim. Medial side, I end up cutting maybe a millimeter or less. Now, there are situations when the knee phenotype is different. Occasionally the lateral femoral condyle, what used to be saying that it is hypoplastic. But we today know, for following the CPAC and other knee phenotypes, that you can actually have these different knee inclinations. But I think here we are not considering those here. So this is the kind of distal femoral cut that I get at the end of my, at the end of my first cut. And then what I look at is on the medial osteophytes. Now, these are all medial osteophytes that need to be knocked out. The osteophyte from underneath the medial collateral ligament has to be knocked out carefully without damaging the medial collateral ligament. And with a flat 10 millimeter osteotome, I knock off this, take out this osteophyte. And this tenting osteophyte actually, significantly reduces the tension on the medial collateral ligament. Then I put my knee in the figure of 4 position, and I'm going to actually do a posteromedial corner release, capsular release only. Now, those of knee alignment, or even functional alignment surgeons are flabbergasted about this posterior medial corner release. And just to say that this posteromedial soft tissue release is actually what is responsible for patient dissatisfaction is, I think you're doing doing great disservice to yourselves and the patient. I don't believe that this soft tissue release makes any difference to the overall patient satisfaction area. And it is, it's a big hoo-ha is made about not releasing this posteromedial corner. But posteromedial corner release is required for any deformity that is more than 15 degrees. Even if I'm aiming for functional alignment using technology, I still have to release this posteromedial corner. And sometimes even do a reduction osteotomy if the deformity is significant. So I'm not ashamed of doing this. In fact, this is a necessary step for any knee that you need to, you need to sublux the tibia forwards, and unless you do this, it doesn't happen. Next is my tibial cut. Now these slides are very old, almost 15 years old. I never evert the patella as is seen in this picture, not anymore. I mean, I stopped doing that for almost 12 years now. But I'm taking my lateral side. You can see that this jig is also very old. So I'm taking my lateral side as a reference and looking at my slope. Now here, basically, you are setting the ankle clamp to be at the center of the ankle. Now, center of the ankle is typically at actually slightly medial to the mid-malleolar point. And as a result, the ankle clamp is set usually either in the center or maybe a millimeter or two on the medial side. But today, if I am actually aiming for maybe a millimeter, 1 or 2 degrees of varus on the tibia to facilitate my balancing, then I will actually, set that ankle clamp right in the center. And when I do that, I am taking my lateral side. Now, depending on what I see on the X-ray, whether there is any significant lateral stretch out, I'll be reducing my cut and doing the fine adjustment here. And after I do that, I have my 4 hormones in place for protection of the various structures around. And I will do this cut. Now, typical varus knee, you will see that you are hardly taking any bone off the medial side. Now, if I was doing kinematic balancing here, I would actually have to assume that my maybe cartilage thickness originally was 2 millimeters. I can't know how much bone loss has been, and then take this cut accordingly. But this is not what I'm aiming for. I'm aiming for a neutral cut with respect to the long axis of the tibia. And this is the typical kind of cut I get, and I measure my resection, how much bone I've resected from the lateral side. And this is the typical resection that I get. Now, anytime I find a lateral stretch out or a sublux knee like this, I'm going to decrease my resection based on the lateral side. And then I will typically end up coming out through the middle of the defect. I'm not going to be bothered about the defect. I'll be dealing with that later on. And that is how I always say. At this point of time, I always find my extension gap is trapezoidal, medial side is significantly tight. Now, at this point, there are various techniques that are possible for medial tightness. You need to knock off the medial and posterior tibial osteophytes. You need to do a posterior medial release. I need to knock off the posterior femoral osteophytes and posterior capsule if there is a fixed flexion deformity associated. So another next technique would be downsizing tibia and reduction osteotomy. But for downsizing the tibia, I need to know what is the femoral size. So I am going to be moving to the femur at this point of time, and I'll determine the femur and determine what rotation I need to get my flexion balancing right. So I put the knee in flexion at 90 degrees and distract the knee, and this is what I see. Significant stretch out on the lateral side posteriorly, especially these patients who are sitting in cross-legged for a very long time. This is how it typically looks. And at this point of time, I'm still haven't done my reduction osteotomy, so medial side is still significantly tight. And I will, many a times I decide on rotation of 3 degrees, which I leave the option of increasing my rotation. So I will put it possibly in 3 degrees initially, put my jig in and take only the posterior condylar cut and take my block off. And then I'll come back to the tibia. I have access to my posterior osteophytes, which I'll take out using a curved osteotome. I'll in fact even do a posterior capsular release if I need to, if there is associated flexion deformity. And after that, I'm coming to the tibia again, because now I know my femoral size. I know the smallest tibia that is going to be acceptable for that femoral size. And you can see how the amount of big osteophyte there is. That is all extra bone that is there on the medial side, which I'm going to knock off. Once I knock that off, that actually gives me my medial balancing. And I'll also do the reduction osteotomy by lateralizing the tibial base plate. And then most of the times I get my balance exactly as I can see here. Now, reduction, I can even change my femoral rotation if I find selective tightness on the medial side in flexion after getting my extension balance right. So aim is to get the balancing right. If I have persistent 2 to 3 millimeters tightness, as you can see, there is some degree of lateral laxity here, and medial side is still tight. So I do what is called as a pie crusting using a 18 gauge needle from outside in, and I'm going to have multiple punctures in the entire length of the medial collateral. I can actually palpate the tight area, but most of the times it's the entire length of the tibia. I end up having anywhere from 15 to 18 punctures in the length, and then I can upsize my poly size by a millimeter or two, and then get my balancing right. So warning is that excessive pie crusting can certainly lead to MCL incompetence. Just be very careful. Never use a 11 or 15 blade. Always use a 18 gauge needle. So this is the kind of result that you can get. This is the kind of mechanical alignment that I'm aiming for. And even the gross looking or grotesque looking knees can be balanced very easily. This is still only a posterior stabilized knee. PS implant has been used here. MCL is still very much intact. A popliteus release is necessary in knees that are fixed sublux. Any knee that is fixed sublux, this is a rotary subluxation, and it is a posterior popliteus coming from the back of the tibia and the fibers converging on the just below the lateral epicondyle. And this popliteus, as you can see here, is actually becomes a deforming force. So many times, almost every time that I see a fixed subluxation of a knee like this, I end up doing a Z release of the popliteus, and I leave that alone, and that actually helps my medial balancing in a great deal. So use of technology, yes. I think if I'm using a technology for significant deformities, I set my boundaries. I think setting the boundaries is extremely important. I set my, for robotics, I will set my, boundary as 3 degrees or sometimes 3 to 4 degrees of tibial varus. I don't go beyond that. Although I believe there are surgeons who are talking about 6 and 7 degrees of virus. Overall limb virus, I will not go beyond 5 degrees. And especially if I'm using robotics, I will accept 2 to 3 millimeters of posterolateral laxity. But I'm going for a functional alignment philosophy rather than strict mechanical alignment. This is an important paper that has recently come out from Australia. This is a randomized study that was comparing kinematic alignment with mechanical alignment, and the paper results have just come out 2 or 3 months back. This is Australian Magdese group, the same person who described CPAC classification. And this was initial protocol that was discussed in BMJ, and this paper has come out in April in JBJS this year. And basically, what they are saying is this has been absolutely at 2 years. There is no difference comparing functional with mechanical alignment at 3 months, 6 months, 1 year, and 2 years. Obviously, mechanical alignment had a higher soft tissue release, so surgeons would certainly tend to prefer it. But at the end of the day, I don't believe that there's no paper today that has shown any superiority of any one alignment technique. So the advice would be that follow what works in your hand. My premise is this, are we risking more than 80% satisfied? If you have to believe 20% as the dissatisfaction figure, I don't believe that is true. I think its figure is of approximately 5% if you ask me. If at the outset 10, definitely not more than that. Are we risking those more than 80% satisfied patients with excellent long-term results in trying to get better outcome in the rest by tweaking what has consistently worked? We are hoping for more tolerance in the coronal plane, putting the knees in 5, 6, 7 degrees or 8 degrees of varus. It's a beast that you cannot control, and the failures that you will see at around anywhere from say 5 years to 10 years. So addressing patient dissatisfaction, you need to address other factors like patient selections, expectations, promises that you make to the patient, the psychological profile of the patient, comorbidities. And my take on knee alignment strategy here is that it's an interplay that you cannot entirely reproduce. And mechanical alignment aims to protect the implants. Conventional techniques cannot reliably reproduce alternative alignments. So you have to use technology for that, but we are going to see another technique soon. Any deviation from neutral mechanical axis has to be implant sensitive. So you need to worry about the long-term survival of that. There is no evidence that alternate alignment strategies eliminate patient dissatisfaction. That is the crux of the matter. I think you have to come up with a paper that patient dissatisfaction has been eliminated by alternative alignment strategies. I'm sorry, that has not happened as yet. Functional alignment with robotics seems to be the way forwards. Thank you very much.
Thank you, sir, for this excellent detailed presentation. So, Hemant sir, the last 2 decades you've been practicing mechanical alignment. The pathology is different. Do you think that varus is coming down nowadays?
No. Today the patients are coming, earlier and earlier. Today I'm coming across patients who are advised total knee replacement somewhere else with a normal looking X-ray.
Okay.
And we are becoming victims of our own, our own success.
Correct.
For example, patient who has only one side disease, second side is almost normal looking X-ray. Patient is demanding that why don't you do the second knee as well, and I refuse to do that.
Correct. Yes, sir.
And you don't fall for these patients. I have had patients who are dissatisfied after a knee replacement done somewhere else, and I asked to see the pre-op X-ray. The pre-op X-ray was normal.
Absolutely normal, yeah.
And if you operate on patients who have almost normal looking X-ray, sorry, what are you dealing with? So your patient dissatisfaction rate, there are reasons, causes lie elsewhere. They're not, in what alignment strategies are used. Sorry.
Yeah. Second thing, sir, in terms of pathology, the gross deformities in arthritic.
Yeah, they're much less now. It used to be said.
Yes, correct.
25 years back, when I started, it used to be every third or fourth knee was grossly deformed. Today, I find every 30th or every 40th knee is deformed. But I am seeing a 20-year follow-ups, and I am seeing a 24-year follow-up, using the strategy that I've used, and I don't see the reason to change.
Yeah. Suppose now we get a less than 10 degree varus with a tricomponent arthritis. What do you do it?
No. I'm using technology, and then functional alignment seems to be, actually a logical way.
Yes.
See, not releasing soft tissues is a good thing. I have absolutely nothing against that. But you need to set your boundaries. You need to be able to do what you're doing. See, if in a conventional technique, if you try to decide that I'm going to put this knee in 4 degrees of tibial varus, you will not realize when that 4 degree becomes 10 degrees. You will not realize. It's manually, physically impossible for a human eye to decipher between what 4 degrees and what 8 degrees is. It's not possible.
Yes.
And I am in fact seeing that when I, with robotics, sometimes I put my tibia in 3 degrees or 4 degrees of varus, and I look at my long leg alignment and I put my, long leg rod to see where it shows. And in fact, I am learning what 3 degrees looks like and what 4 degrees look like. So that, I'm using conventional, I use those, my muscle memory, so to say.
Yeah. Thank you, sir. So Deepak, sir, anything to ask? Deepak Dave, sir.
Hemant, you specifically mentioned about the popliteal release in one condition. Suppose by accidentally with the blade, the popliteus cut, which happens often. What is your suggestion?
It doesn't seem to matter. I mean, popliteus release doesn't seem to be causing any major, hassles. We make a great deal of popliteus, especially in valgus knees. It's supposed to be a great stabilizer in flexion. It doesn't seem to be matter. Whether popliteus has any great role. Popliteus certainly has a role as a deforming force, especially in fixed varus. That much I am 100% sure. Because many of these knees that do not get balanced very easily, as soon as you release the popliteus, the knee gets balanced. So popliteus release is extremely important for fixed varus subluxation.
Dr. Hemant, great presentation as usual.
Thank you.
I have a question for you.
Yes, please.
You said that you will not set a valgus correction angle more than 6 degrees. But what
rarely. I do that sometimes, but not the 9 degrees that KM guys talk about.
No, but we have seen that a lot of the times if you want to cut the femur at 0 on the Mako as well, the valgus correction angle sometimes is 11, 12 degrees also. So are we doing some sort of functional alignment by cutting it in 5 degree varus, which is maybe a varus which are compensating on the femur rather than tibia?
We are actually doing that. See, many of these, ultimately, many of these techniques that we use, ultimately, they all come together at some point of time. So today, even though I'm not a purist for mechanical, I would not call myself purist, but then adjusted mechanical alignment effectively, veers towards functional.
Right. So we were always doing functional. That's what I think, because I don't think we are so good that we'll get 0 cuts and a 0 aligned knee ever in our practice. Probably
that's absolutely right. That's absolutely true.
But as long as we balance, it works. I think that
balancing is absolutely the critical part. The alignment is not so critical. Balance is absolutely critical, because we have seen tibia badly positioned, but still, if it is well balanced, it seems to work well for a long time.
Thank you. I think that's the message to the younger people. Balancing of the knee is the key, right? The alignment may be this way, that doesn't really matter. So you can make all cuts you want. If you don't balance it, it will fail fast.
Yeah, that's true.
Yeah, that's absolutely true. Fantastic lecture. And
Yeah,
I think
thanks,
that's functional.
Over to
Krishna, you're muted.
Yeah.
Yeah, Ashok, you can take over.
Yeah, I can go ahead. Yeah.
Sir, you need to
stop sharing it. Yeah.
stop share your screen. Yeah.
I'm still sharing?
Yeah.
Sorry.
Yeah,
I'm sorry.
Because
all right. Yeah, done
it's
that.
over to Vikas. Yeah. Yep. Yes.
Can you see my screen?
Yeah, yes, we can see.
Yes, sir.
Yeah. Thank you, Ishks Education Committee, for getting me on board for this webinar. So I'm a pure KA surgeon, so to speak, but I do understand, because I came from a mechanical background for initial part of my training and converted to KA last 4 to 5 years, and do understand from Suhas and Krishna what functional means. And I do have access to technology, but this particular talk is how to do a KA knee using a conventional instrumentation set. The only extra instrument that you need is a caliper. And we're going to talk about what are the surgical steps that guide it. Now, a pure KA technique is a measure dissection technique. What do you mean by that? that you use a manual instrumentation set, but you caliper verify each and every cut. The aim is to set the femur and tibial component parallel with the patient's pre-arthritic joint line. And Suhas did mention the the joint lines, the distal femur joint line, the posterior condylar joint line, and the tibia joint line, which is the coronal as well as the sagittal joint line of the tibia. Now, K performed with manual instrumentation set is highly accurate, and it has a very negligible learning curve. And in total, you do 10 caliper verification checks. Now, the four are in the femur, the medial and the lateral distal femur, the posteromedial and the posterolateral femur, 2 on the tibia, the medial and the lateral, 2 on the patella if you are replacing the patella, and 2 for the femoral offset if you are in the habit of measuring the femoral offset, 1 pre-op and 1 post-op. Now, the target of the cut is the thickness of the distal and the posterior of the implant. For any standard implant, let's say for this implant, it is a 9 millimeter distal thickness and 9 millimeter posterior condylar thickness. And this is the amount of bone that you want to remove on the femur with your saw. Now, cuts are made after obviously compensating for the cartilage and the bone wear. And we'll see how you compensate for this cartilage wear. On the tibia side, the resection is done to restore the native varus valgus in the coronal plane and the slope in the sagittal plane. And this eliminates or reduces the need for any soft tissue releases. So 9 millimeter cut, this is what you want to remove. Now, distal femur is cut and immediately measured with the caliper. Now, in this particular example, once you cut it, the target for this particular implant is a 9 millimeter thickness. Now, if the cartilage is missing, so you compensate by 2 millimeter, which is by standard, the thickness of the cartilage is taken as 2 millimeter. You compensate by 2 millimeter. And once you measure, since the average thickness of saw blade is 1.19 or 1.27, you subtract 1 millimeter for the thickness of the saw blade. So this, in this particular example, it comes out to be 6 millimeter, which is accurate for this particular. On the posterior side, once you have referenced on the posterior femoral condyle, you want to cut parallel to the posterior condylar axis. In this particular case, it is 9 millimeter thickness, and because the cartilage loss, you compensate by 2 millimeter, and for the thickness of saw blade, you compensate by 1 millimeter. Now, on the tibia side, you match the coronal slope and the sagittal slope of this patient. For, let's say, CPAC 1, which has a downsloping tibia, you shift the tibial zig at the ankle in a slight lateral position, which in turn will produce a varus on the tibia. This varus is actually measured with caliper and recorded in a sheet of paper. Now, this will be shown on a video. So any standard varus knee, this is how you begin. So it's any kind of exposure can be used. For a K knee, a subvestous approach is preferred. For this particular video, it's a medial parapatellar approach. At the start of the surgery, only the anteromedial aspect of tibia is exposed and no more, because we're trying to prevent any soft tissue releases. The patella is prepared as per the need of the case. The meniscus is removed. In this particular case, the cartilage is missing on the medial part of the femoral condyle. And as a starting step, I have used a saw to remove any remaining cartilage on the healthy part of the lateral condyle. A point equally distant between the top of the notch and the trochlea is marked, which is the point to enter into the femoral canal. Now, a standard extramedullary zig is inserted, but here the aim is to reproduce the distal condylar line of this patient. So these two paddles need to sit equally on the femoral condyle, and we forget what the varus valgus angulation is for this particular case. Here it is a 0 degree, but we are not bothered. Now at this point, we'll fix the distal cutting block against the femur. This distal cutting block is by design supposed to take out 9 millimeter of bone distally. But since we have already removed the 2 mm of cartilage, we will compensate it before the cut by shifting this block to a -2 position. So we started at 0 degree on this block, but we've shifted it to a -2 degrees. And then we'll go ahead and remove the distal medial and distal lateral part of the femoral condyle. Now, after cutting, this is immediately measured, and this is 6 millimeter, which is fairly accurate. 6 plus 2, the thickness of the cartilage is 8, and 1 millimeter of the thickness of the saw blade, which makes it 9 millimeter. The second step is to use a posterior referencing zig, which is paramount for doing a kinematic knee, which is set at 0 degrees of rotation. No external rotation is given. And this is fixed to the distal femur, and the sizing of the femur is done. As part of the K steps, the first cut is taken is the posterior femoral condyle. You verify, obviously, if you're not notching. And you want to remove equal amount of bone from the posterior femoral condyles. Now, after this posterior femoral cut, before you proceed further, this posterior medial and lateral cuts are removed and again caliper verified. These both are 8 millimeter because they have no cartilage that is missing. 1 millimeter is for the thickness of saw blade. 8 millimeter cuts are fairly accurate. Now, further ahead, you do your rest of the chamfer cuts, and the femoral preparation is complete. Obviously, at this point, you will remove any osteophytes on the femur, especially the one tenting the medial collateral ligament, as shown here. This will bring the collateral ligament back to its native length. You can do a trial on the femur at this point, see how the knee looks like. On the tibia part, the osteophytes on the medial side is removed, and the tibia zig is assembled. Here, as you can see, the cartilage is intact on the lateral part of the tibia, but it is missing on the medial side. And in fact, some amount of bone is also missing. A point equally distant from the tibial spine, both median and laterally, is marked because that becomes your reference point. At the start, the tibia zig is assembled like a mechanical axis, and the slope is matched by using an angel wing. This will recreate the sagittal anatomy of the tibia. Now, to match the coronal slope, I have shifted the ankle, as you can see in the picture, towards the lateral side. And the first point of reference is to mark from the lateral, which is the normal part of the tibia. Now we'll remove it and again measure on the medial side from the point equally distance from the tibial spine. Recheck again, so as to be sure that you are not over resecting. Once I'm satisfied, the tibia zig is fixed to the proximal tibia using pins. And the standard proximal tibia cut is taken. Now this matches the sagittal anatomy of the patient, and the valgus varus on the ankle part of the zig matches the coronal slope. After you take the standard tibia, proximal tibia cut, this is immediately measured to confirm that the lateral cut, because the minimal poly in this particular implant is 10 mm, the lateral side should measure as 9 millimeter. And the medial side, depending upon cartilage and bone loss, could vary between 6, 5, or 4 millimeters. 9, it is a fairly accurate cut on the lateral side, and the medial side is about 6, 6.5. 6.5 plus 2 cartilage loss makes about 8, 8.5. At this point, for the completion of the surgery, we'll remove any remaining medial posterior osteophytes and any remnant part of the meniscus. Removal of any osteophyte around the knee is necessary to restore the native length of all the collateral ligaments. Now, once you've completed the steps and your measurements on the caliper are within the prescribed technique, the knee would have balanced itself without any soft tissue releases. You can straight away go do a trialing and then go ahead with the rest of the case, where you can mark your tibia by a free floating technique. So it's very stable in extension and fairly stable in flexion. Rest of the steps are similar for any other case where you prepare your tibia. Now, these are just a few steps. If you are not accurate to within 0.5 millimeter of your prescribed cuts, so if you have under resected, you can use the same zig and press your saw blade to remove about 0.5 millimeter or 1 millimeter of bone if you're under resected. If you have over resected, you can use a spacer zig like this. This is a 1 millimeter zig against the 4-in-1 block. In this particular case, the distal resection was over extra by 1 millimeter. You can use this spacer zig to complete and fill in with cement. Similarly, if your posteromedial and posterolateral cuts are inaccurate by a millimeter, you can compensate by taking a recut by using this adjustment zig. In this particular case, we needed to remove 1 millimeter of extra bone from the posteromedial aspect. Now, to algorithm of balancing a KA-TK, the North Star in KA case is your femur. You absolutely must surface match the femoral part. Anything that for the balancing that can be done is on the tibia side. You can redo a varus cut. You can do a extra cut on the tibia to balance the knee. These are, once you've done the preliminary trialing, you would know, and you can change the cuts on the tibia to balance the knee. So tibia cuts is the only end that is modifiable. So if you have to remove an extra millimeter of bone on the tibia, you can use the same zig and press your saw blade to remove an extra amount of bone. If more than 1 millimeter extra bone needs to be removed, then you'll have to use an extra zig, which is called as a varus recut zig, like here, to remove extra bone on the tibia. Examples of few of the cases. This is a extreme varus, more than 15 degree of tibia, balanced with a kinematic aligned knee technique. So in conclusion, kinematic alignment preserves the patient native joint lines, soft tissue envelope, and natural kinematics. Calipered measured unrestricted kinematic alignment has shown better patient-related outcomes without an increase in implant failure rate, at least in the first 14 years. Bone cut with conventional instrumentations were 95% accurate to target. Thank you.
Thanks, Vikram, for this beautiful, excellent demonstration of the KA with mechanical instruments. Yeah, Vikram, for your first question, the lateral laxity, how do you account? Do you take a less cut?
So this is my take. I believe there's very few cases where there is true lateral laxity. Part of this lateral laxity that you see on a pre-op X-ray is because of the lateral subluxation of the tibia. Once you restore the alignment, this lateral laxity falls back into patient's own original soft tissue envelope tension, and you don't need to balance. If I feel that lateral laxity is there and it is more than 2 or 3 millimeter, then there are two strategies to do it. You can take a lesser cut on the lateral side. And if I have already taken a cut and I feel that lateral side is opening in extension, then what I usually do is I ended up grafting the lateral side with a 1 or 2 millimeter of bone and then cementing it.
And your preferred implant in a K, it works with all the implant, only posterior referencing is the key.
Posterior referencing is the key, but I would not prescribe using a KA technique with a PS implant because PS implant dictates how the knee moves. It works very well with a cruciate retaining knee or a medial pivot knee.
The radius doesn't change. Radius doesn't matter.
So medial pivot design is actually a fixed radius design. So the radius of the implant does not change. But for a lot of cruciate retaining knees, it is a variable radius designs like a Persona or a similar implant, and the radius can change.
Dr. Vikram, can I ask a question?
Yeah, sure.
Yes, please.
Yeah, so the the elephant in the room and the reservation most surgeons have, and which Dr. Wakankar also alluded to, is the varus failure. So a couple of things, if you could clarify the long-term outcomes from the Dorset as well as the Howell study, which are 13 and 17 years, with the average varus being what it is. And the difference in the loading pattern for a mechanical knee, which is in varus, versus a kinematic knee in varus. What about the medial pressures, which we know from the pressure sensing data?
So excellent question, Suhas. So we know from the long-term studies that we have available that the varus collapse in a KA knee at 14 years or 17 years follow-up does not happen, or at least it is not greater than the mechanically done knee. But the biomechanics one must need to understand, if you do a well-balanced KA knee, you're balancing the forces on the joint, both on the medial and the lateral side. However, on a mechanically done knee, the loading is preferentially on the medial aspect of the knee. So if a MA knee ever fails, even if it fails at 10 or 15 years, it fails in varus, it fails on the medial side. So they have done in vivo and vitro studies in cadavers, and they have measured the forces on the medial and lateral side in a KA knee, and they found that the distribution of the load after a KA knee is equal and nearer to the native joint on the medial and lateral side. But in a mechanical knee, it is loading on the medial side. So by theory and by stereoisometric studies, it is not a greater load on the medial side, even if when you're cutting the tibia in varus of 4 to 5 degrees. So it will not fail in varus.
Yeah.
Now the
so it boils down to the knee adduction moment being
Yes.
much larger in a mechanically aligned knee versus a KA knee, which has a shorter knee adduction moment because it's closer to the center of gravity of the patient.
Exactly.
Do you accept that explanation?
Yes.
Okay.
Absolutely. Now, my reservation or my thing that I need to solve is that a lot of people do not understand. In an Indian setting, there is a peculiar type of varus, which we call as a tibia vara. So if you look at a standing scanogram of a lot of Indian ladies, there is a bowing in the tibia, which is in the metaphyseal part, and it is different from the varus arthritis that is present within the knee. So for the sake of clarity, you have a varus because of the intra-articular wear of cartilage and bone in the joint itself. And there is a slight bowing in the tibia, in the proximal part of the tibia. Now, this is present for this particular patient since she was an adult, since 18 years of age. Now, this is a peculiarity of an Indian anatomy. Now, if you measure these patients, the coronal alignment in these patients, so they have a coronal alignment, let's say about 3 degrees in the tibia, and you add about 4 degrees of tibia vara, which is in the metaphyseal varus. Now, if you combine these two components, sometimes the tibia cut requires is close to 7 degrees. Now, this particularly does not happen in a Caucasian population because they do not see this particular subset of patients. Now I've talked about it and I have reproduced this anatomy in a lot of my patients. Now the question whether these extreme cuts will survive can only come from our own published studies, because these kind of studies are never going to get happen in Europe or America. Now, at least in my hands, in the last 5 years, those patients that crossed 5 degrees of varus, so to speak, 6 degrees or 7 degrees, have done excellent, but at least none of them have shown varus collapse in the short-term follow-up, which is about 4 to 5 degrees.
But Vikram, I think 2 points here. Our observation is that about 30% of the patients do have excessive lateral laxity. And we have the publication from Dr. Arun Mulaji on MR studies, which show that although MCL doesn't contract, there is definitely a proportion of patients who have got LCL which stretches out because of the varus deformity. And that is the reason why a lot of the times, if you observe, you just resurface the femur, you will still have to adjust the tibial cut and do something on the medial side to balance the knee. So that is one point. And second is, it's probably not a good idea to correct extra-articular deformity with an intra-articular cut. So we must not cut 7 degrees varus, still cut at 3 degree varus based on what is intra-articular, and that probably is more sensible. Because if we correct all that extra-articular deformity in the joint, that is also not good. Trying to make it 0 is also not good. Probably a middle ground in between the two, like if it's 7, maybe go for a 3.5, 4 or 5, probably is a safe idea. We have data about 7 years out now with such 5 degree varus cuts, which is in between, and they don't collapse at 7 years.
So I think this is where robotics scores over manual KA, where once you put the femur on and do your ligament analysis again, and if you see what Dr. Krishnakiran described as excessive lateral laxity, you can make better adjustments on the tibia in order to mitigate that lateral laxity. And then beyond a point, which is 4, 5, 6 degrees based on the surgeon, you'll have to do some amount of release on the medial side in order to compensate and get a balanced knee within 2 millimeters of lateral laxity, which is usually most of the surgeons would target in extension. Flexion is a little more forgiving.
Yeah, excellent. Ashok, we can carry on. I think we are running a little bit late.
Yeah. Thanks, Vikram. Thanks for the knee session. Kiran, it's over to you. Arun?
Yeah.
Thanks, Arun, for joining again.
Thank you.
Yeah, Arun, go ahead with your talk, balancing the hip.
Yeah. Thanks to Ish for the opportunity. So I think as far as the hip goes, it's fairly standard teaching that's held sway for a long time. I guess not much has changed as compared to the knee over the last 10 years. So it's a basic talk. Leg length discrepancy in THR, we assess through radiological measures. Basic pelvis AP view, we mark fixed landmarks on the pelvis, get the pelvic axis and draw perpendiculars to a fixed point on the femur, usually the most point prominent part of the LT. And then we get the LLD that is there. Also important, it is to look at how the patient is actually functionally perceiving his LLD. The blocks method is a very standard method. You place blocks under the shortened leg and see at what position he feels best about. So generally a combination of the radiological and functional parameters are taken into account before we embark on a full-fledged LLD correction. And so how much LLD is acceptable post-op is something that's been extensively studied by a lot of people. Less than 5 mm is probably ideal. People don't notice 2 or 3 mm change in limb length, especially lengthening. 5 to 10 mm has been shown to be reasonably well tolerated without much symptoms. But if it is more than 10 or 15 mm lengthening, then that shows up in most people. They feel their leg to be longer. So less than 10 mm would be a good goal, and less than 5 would be an ideal situation in post-op LLD correction. So coming to offset, so defining femoral offset is when we refer to femoral offset, it is generally the horizontal femoral offset. We draw a line along the center of the anatomical axis of the femur, and measure the perpendicular distance from the center of the femoral head to this line, and that gives the horizontal offset of the femur. The importance of the horizontal offset would be mainly twofold. One is it defines the abductor lever arm. Here A is the abductor lever arm and B is the lever arm for the body weight from the center of the body to the center of the hip. And if A, which is femoral offset, if that is lower, meaning if the offset is shortened, then the abductors have to do as much more work to maintain the hip against the body weight. So if we shorten the abductor lever arm, the abductors have to work more and they become more tired, leading on to a Trendelenburg gait. The second importance of offset is about impingement. So if we shorten the offset, then the GT tends to go and hit against the pelvis within a shorter range of movement, and this can be a cause of reduced range of movement as well as dislocation. So if we maintain the offset, the femur is away from the pelvis, and that will improve our range of movement before impingement happens. So how much offset change is again tolerated has been fairly well studied. I guess offset restoration within 0 to 5 mm plus 5 mm would be the ideal based on the current evidence. If we reduce the offset more than 5 mm, then as I said, there is poor abductor function. Increase up to 3 to 5 mm has been shown to be advantageous in a few studies, but excessive increases may not be good. So what we know is 0 to plus 5 mm would be an ideal offset. Reduced offset is certainly not good. Excessive offset, plus or minus, there is no concrete literature, I would say, at this point of time, but more than 5 to 10 mm lengthening may not be a good idea. So how to adjust? There are various options of femoral stems that help with this measure. So there are two variations that are possible. You can have one on the left, either the stems come as valgus, standard, or varus necks. If you have a valgus neck, that will reduce the offset, horizontal offset, and increase the length, as you can see from the blue dotted arrow. If you have a varus neck, meaning like a 125 or a 127 degree neck stem, then it increases the offset but reduces the length. On the right, you have a different kind of offset adjustment. If you have a high offset stem, there is more offset, but the length is same. You can see the purple heads are all at the same vertical level. If you have a low offset stem, then there is less offset, but again, the length is maintained. So we must know about these stem options. This is one commonly available stem corral that has several neck options. You have the standard, you have the high offset marked in yellow, which and a coxa vara stem where the neck angle is changed. Also, you have the short neck option. So multiple options are available. Just to illustrate the difference, here on the left, you have a 132 degree stem, which is slightly lower offset for this patient. However, if you, in the same position, if you put a 127, which is a varus stem, it matches the patient anatomy more closely. An example, a gentleman with about 4 to 5 mm preoperative shortening on his pelvic X-ray. Here, the center of the prosthetic neck is shown as a blue dot and the center of the hip is shown as the green dot. If we want lengthening, we want to position the blue dot slightly above the green dot so that when we reduce the hip, it lengthens. If we want to increase offset, then the blue dot has to be medial to the green dot so that there is increase in offset. So here we've kept with 137 stem, and I'll just, it's a short video on how to adjust. So here, if you go to 127 stem, it probably matches the anatomy more closely. But there are a lot of situations where we don't have these options. So how will we adjust without that option? So here I have 132. We increase the neck length or the head length, and then up to 5. And then we can go up to 10 mm. You can see that it has increased the offset, but it has also increased the length. Then we have to, during templating, lower the neck cut, the level of neck cut, so that the stem can be sunk down at the time of real placement. And this has been the age-old method for doing it without too many stem options being available. So how to assess this intraoperatively? There have been many measures of doing the LLD. I think more than 20 ways have been described, from Ranawat's method to coaxial stitch method from our own Dr. Vijay Bose. So Dr. Ranawat's method has been using a Steinman pin in the infracotyloid notch. And the logic is to keep the pin as close to the center of the hip to reduce the variations from the hip position. So I'll just show you how I do it. So I just make a small drill hole on the supraacetabular region, place a screw with the threads position, and use a thread, mark a point on the femur with the cautery, and this will give us the preoperative length of the hip. And we also mark it where the thread comes against the GT, so that when we can reproduce the same when we go next. So next we have we are keeping the templated broach size where the thread comes against the GT, so that when we are keeping the templated broach size where the thread comes against the GT, so that when we so here the neck cut is marked. You can see that I marked the femoral head center as well. It is marked. So this is, again, we can measure the femoral neck length as well. So you mark a point on the intertrochanteric ridge from the femoral head center, measure it, make a note of it, and we'll try to reproduce the same as we go along. So after trialing, I am measuring the post-op femoral neck length from the center of the prosthetic head to the preoperatively marked intertrochanteric line. That will give the femoral neck length. And after reduction, I use the same thread to see whether I have matched the preoperative length marked on the femur. So this is the method I've been using. Also, if you're having the advantage of supine positioning with the DAA, you can easily get an X-ray and see where you are with respect to length and offset. And to assess for stability during surgery, there's a posterior hip, right hip. So for assessing posterior instability, we flex the hip to 90 degrees flexion, 45 degrees internal rotation, and see if it is stable. To check for anterior stability, extension, and up to 20-degree external rotation. Generally, at least in this range, I want my hips to be stable without dislocation. So this is a short video showing the same. So right hip internally rotated to more than about 45 degrees and stable, and then bringing the same to extension, external rotation, and noting the hips to be stable. So what if it is unstable at this point when we are checking? And in this case, we have to remember impingement and as an important cause of dislocation. So if there is posterior instability, generally there is impingement in flexion, internal rotation. The impingement is somewhere anterior and dislocation is happening posterior. If there is anterior instability, there is impingement in extension and external rotation. The impingement is somewhere posterior and dislocation happens anterior. Can be divided into three parts: component bone, and bone impingement. Component impingement, acetabular position is the major factor. Suppose if you have retroverted the cup to about 5 degrees instead of the normal 20 degrees, there will always be anterior impingement and posterior instability. Component bone impingement happens often due to anterior osteophytes on the neck or the acetabulum, and these have to be removed. Bone-on-bone impingement is mostly an offset issue. Therefore, we have to increase the offset as we discussed before. So how to assess for this intraoperatively? We can generally put a finger as the hip is flexed and internally rotated, put a finger between the neck and the cup and see if there is impingement happening between the neck and the rim of the cup. If this is happening, then it is due to component impingement. If it is the GT hitting against the pelvis, that can also be felt in most cases. The other test is Ranawat's coplanar test that gives an idea of the combined anteversion of the cup and stem. Again, if your hip is dislocating, we are first looking at version, and Ranawat's test, we keep the acetabulum and the rim parallel to each other and measure the angle between the leg and the horizontal. So this will give the combined anteversion. If this is off, then we are looking at correcting the version. So in brief, if there is component impingement, we have to correct version, acetabular or femoral. If it is bone-bone impingement, then we have to increase the offset with a longer head length or a high offset stem. If it is osteophytes, then simple to remove the osteophytes. An example, a lady who had a femoral neck fracture had an initial uncemented bipolar that dislocated after subsidence. She was revised to a cemented stem, and again you can see that the offset has not been well compensated. So this was revised with the cemented stem with a dual mobility construct, and here you can see that offset restoration has been done and she continued to remain stable. So in summary, limb length discrepancy ideally should be within 5 mm. Plan the neck cut, check intraoperative with a fixed pelvic landmark. Offset 0 to plus 5 mm preferable. Plan with the template, plan your stem, and if you can use a C-arm intraoperatively to check the offset. Stability, check intraoperative range of movement, look for impingement if unstable. If it is component, correct the version. If it is bone-bone impingement, increase the offset. If it is osteophytes that are causing the component bone impingement, we have to remove them. Thank you.
Thanks, Arun, for this detailed balance in the hip and the offset. And it's Ravi.
Yeah.
Yeah, share the screen, Ravi. Yeah.
I'll share the screen. Is it visible?
Yes, Ravi. You can go ahead, Ravi, please. Yeah.
Yeah, I just make it slideshow. Yeah. Good evening, everyone, and thanks, Ishk, Ashok, Lanshekar, Krishnakaran, Pachori sir, for the opportunity. My current topic is stem selection in primary THA. I apologize for my voice and bit of unhealthy body. Yeah. So all of us know the father of hip replacement with the philosophy of low friction, orthoplasty, John Chandler, and the stem used for every problem was a cemented stem. And many follow-up studies have shown beyond doubt that it has worked beautifully. And of course, the current situation or the present scenario of India or the present world where we're heading, so it not only depends upon a single philosophy, like one stem design should fit all the problems. It should be individualized as per the femoral anatomy and so many things. When you see this slide, there are so many pictures of the stems, and of course, we'll definitely think, so there is so much variation in the stem the design, geometry, fixation methods, and so on. So that's why is so many stems or the development has caused confusion. So I believe what factors we should integrate or consider while designing is the type of the design what we have, what surface treatment, whether what type of stability it gives, and how the osteogenesis may help in the integration. We have so many stems now than ever, but has the stem selection become easier? It's not become easier because more designs doesn't mean that better decisions. It should be the stem should fit the femur, not our philosophy. So when my simple algorithm it starts with the patient, whatever patient I'm choosing, depending upon the age, activity, and demand, whatever bone I'm dealing, the quality of the bone, door type, A, B, C, and whatever morphology I'm dealing of the femur, proximal femur, or whatever version I required, depending upon the anatomy, then what is my goal, like fixation, offset, leg length, which is beautifully covered by Arun just now. So the end step point is stem is based on these points, like patient, bone, femur, and what is my goal of fixation. Finally, the stem, it's not the other way, like we decide the stem and try to fit in the bone, whatever available. It's rather we study the bone and then go for the final fixation. The major decision in fixation strategy is young and good bone. Let's apply these 4 principles, what we like patient, bone, femur, and goal in the practical scenarios. If the patient is young and good bone, so definitely predictable cementless first fit implant will be ideal. If they are elderly and fragile bone, we should not force or for the fresh fit to cause the fractures or untoward actions. We should consider the cemented option as well. The gray zone is where age alone is not a decision. Like there are many other factors, bone quality, door index. And one of the teaching in our hospital is for every hip, we do door index irrespective of whatever patient age is and document it. So our predictability of the fixation should overscore our fashion of using some implants. So then why this matters so much is ultimately if there is a fragile bone and if you do an aggressive frostbite uncemented implant, the fracture risk definitely increases. So lesson is, we should not cement everyone who is elderly. It is to choose a definitive fixation strategy which helps for reliable fixation. So cemented fixation still remains a good modern option in various type of femurs. So the stem design should be based on tapered wedge, and whether it is fully coated or whether it is short stem or it is cemented or not cemented. So this also there are a lot of short stems which are very attractive, but it has high potential advantage of bone preservation, theoretical advantage, potential future revision advantage, and useful some selected morphology. But they does not score in every case and may not be suitable in every femur. So short and femur doesn't mean that short stem doesn't mean that it is superior and is different. Many studies have shown the results are not so great. So one of the other important factor, this is Dr. Vijay Bose always tells the neck shaft angle. Arun also beautifully covered. So in our hospital, we have 3 stems, 127 accolade and 132 accolade and 135 standard. And also we have short neck of collar coral. These 4 stems are there. My good friend Krishna Kiran always tells you should keep a polar stem as well. So that we are looking for, because the neck shaft angle also is an important predictable factor to determine what type of stem we use. So for example, if it is very varus, we can use like polar stem. If it is in between, we can use like accolade stem like 132, 127. Or if it is like more of valgus, we can use a standard coral stem 135. So neck shaft angle also carries a lot of weightage. So then for the theoretical aspect of understanding the types of the stem, 2020 classification, the newer classification, they classified type 1 into 4 types, where type 1, B and C are majority are neck loading stems. 1D is short tapered stem. 2 is single wedge, 3 is double wedge, 3 is gradual taper. In that, there are 2 different types, and 5 is diphysial engaging stems, and 6 is modular stems, and 7th is anatomical stems. Let's go one by one. Short and ultra short stems, the femoral neck holding stems, these 1A, B, C. So these become very famous, but especially in the past, and of late they don't have good attractive long-term survivorship results. That's why they're losing the popularity. Especially the lateral flare-based, like proximal-like stems, it causes a lot of metaphyseal bone loss than the long stems itself. For example, we use a accolade stem and use a proximal stem. If they become loose, or when we are revising and we're removing, the proximal stem will cause more metaphyseal bone loss than compared to the stems which are like accolade or coral itself. So that's why it has lost its interest. In one, majority is 1D. 1D is like actis-like stem, where it has 4 principles. One is it is triple tapered geometry. It has a collar, and it has HA coating, which is duofix philosophy. What they have, and it is more suitable for DAA. Type 2 is single wedge. It's conventional single wedge. It is only from medial to lateral. There are 2 planes, medial to lateral and enteroposterior. In single wedge, the wedging in the metaphysis is from medial to lateral. Enteroposterior it is plain. So its preparation requires just broaching and no distal reaming. So example is accolade 2 stem. You can like from the striker. When you go to the type 4, so it is tapered. 4A is tapered round like a Mallory head stem, and 4B is J. Muller stem, like whereas the proximal surface is rectangular. So they have gradual taper and they are metaphyseal filling stem. Type 5 is like cone Wagner like stem. They're like diphyseal engaging stem. They have tapered spine and cone shape. 6 is divided further into A, whereas modular neck, like it has modular neck in trial and also as real implant. But there are a lot of risk of metallosis and breakage at the junction. So of late, it is, not so popular. Then comes the 5B, which is the cylindrical solution-like stem. The majority are cobalt chromium, and also it is fully coated stem. And because of the lot of implant breakage, thigh pain, nowadays it is not much used. Type 6B is a modular body type, like a SROM-like step, where we can adjust offset leg length without affecting many factors. It is very useful in a patient where has a proximal 3D anatomy is disturbed. For example, dysplasias, altered malnetted fractures, previous osteotomies of the proximal femur. These we can alter the anteversion or decrease the anteversion depending upon the need. So it is basically a metaphyseal fixed stem with diphyseal loading. The stem or the fluted stem loads diaphysis. The wedge, what we use in the proximally, it will help for the fixation. So type 4 anatomic stems, I don't have much experience on this, but as per the literature goes, it's a curved fit and fill stem with a lot of iatrogenic and postoperative fractures. It's of late not been used much. So this is a slide I've taken from Dr. Vijay Bose, one of the presentation in his conference. Sir always tells keep it simple. How to simplify this classification? So there are stems which are like ream only stems, like a Wagner stem. They are diaphyseal engaging stems. There are some stems which ream and rasp stems. So the metaphyseal diaphyseal fixation stems. There are rasp only stems like metaphyseal stems, like accolade stems, proximal fitting stems. So whether these all stems needs a modernization, of course, for our Asian patient because of the geometry of the proximal femur, what we have, and the shape of the bone, quality of the bone, and so on. So we are very proud. After August 15th, the Asian-based stems and cup were launched by Indian company through Dr. KK and Dr. Vijay Bose sir. So hopefully it will be a next solution for many complex scenarios what we have in India. Let's go one by one example. So case 1, young active male, Dore, good metaphyseal bone. So with the background of what previous slides we studied, I think cementless metaphyseal fixation stem will be better. In this case, we've done the same and patient is doing well. Case 2, 72-year-old woman, dorsey, fragile bone. So here, either I will use a collared neck or I'll use a cemented fixation. In this case, we've done a cemented fixation, patient is doing very well. So case 3, there is a DDH, previous osteotomy, abnormal version, excessive anteversion, geometry is altered, the metaphyseal diaphyseal junction is altered. So in this case, my fixation will be metaphyseal fixation. My loading will be in the diaphysis, and if needed, an STSO. For example, this is the case. So we're done a subtrochanteric osteotomy and SROM-like stem, and the patient is doing very well. So this is one of our case. Dore, much has been spoken in all the conferences. This is one of case done elsewhere. This is 9-year post-op for a juvenile rheumatoid arthritis. Bilateral hip replacement was done, and you can see already there is a proximal osteolysis in zone 1, 2, and 3, and 4 because of the stress shielding, the potting effect of the stem. Because it's not only the choosing the stem, it is the right way of doing it. Whenever you are engaging distally for a metaphyseal stem, so it will get potted in the distally and cause stress shielding and cause metaphyseal bone loss. And with a small trivial fall, like this is explanation and animation based pictures. So how this is how they become loosened thigh pain, and sometimes they break also. So they had a small injury and she had a fall, and she came like this. Both the sides there were stress shielding fractures, and infection was ruled out, and we revised with the distal fitting stem and augment on the left side. Right side we retained the cup. This is follow-up of 9 months, and follow-up at 15 months, and follow-up at 4 years, and this is follow-up at 7 years. So it's doing extremely well. So finally, the stem has another job as well. It's not just the fixation. As Dr. Arun told, we need to maintain the upset to maintain the abductor tension. We need to maintain the equal limb length equilibrium for a proper gait and stability. We need to maintain the proper version to have a good range of movements and to prevent impingement. And finally, the fixation helps for the longer term survival. The stem which is well fixed does not mean that it is given a complete solution or a complete solution to the hip problem. So it should fulfill all these 4 games along with survive safe. So what I would change in my practice is the 5 things. Stop thinking in one default stem, like I'll use one company stem, one cycle. Think about the multiple available option. Think about the geometry of the bone. Think about all the aspects of the femoral anatomy and decide about the stem. Morphology and bone quality should predict my fixation. Where should I fix? Whether in metaphysis or diaphysis, or supported with cement, non-supported, whether to use collar, non-collar. So that should dictate our choice of stem. And cemented pathway should not be a forgotten way. We should have we should learn the art of cementing, and we should keep it as a backup for every hip you do. Short stems can be used selectively. Of course, I don't have much experience in this. It's not an ideal stem, is what I can say. Choose a stem which we can reproduce offset, leg length, version, and proper fixation. So we should spread our knowledge and selection towards personalized stem selection rather than individualized stem selection. So finally, the patient, the bone quality, the femur morphology, the fixation type should dictate the stem. So the popular stem should not be our choice of stem. It should be the stem which best matches the femoral anatomy. I thanks for the opportunity. I'm open for discussion.
Thanks, Ravi, for an excellent presentation about detail. The message is clear in the last slide.
Yeah.
What the patients deserve, the patient-specific stem, not to have the one offset, have a multiple 2 offsets at least. And always Pachorisa says, keep a cemented stem backup to depending on the bone interpretive. It's thanks, Ravi, for even still you're not well joining this meeting, educating the juniors.
Thank you for the opportunity, everyone. Yeah.
It's over to Pachori sir. Pachori sir is in the line?
Yes, sir.
Yes, sir. Thank you, sir.
Yes. Share करना. Share इधर.
So to all the fellows and the juniors, this presentation by Pachori sir is an art of cementing. So I don't think you'll be seeing, but this is a must to see and watch his presentation. Yeah, we can see, sir.
Ashok, can you hear me?
Yes, sir. Yeah, we can hear you, sir. We can see the presentation.
I like to thank actually the education chair, Dr. Ashok and Dr. Krishna Kiran. Thank you very much for taking this academic program of the Ishks on your shoulders. This is a greeting from my hospital, Shalvi Hospital, and the title actually was given to me by Dr. Ashok Rajgopal, actually, Forgotten Art of the Cemented Hip Orthoplasty. This is a very important slide and the statement of John Charnley before he died. Just see, there is no doubt that in orthopedic surgery, acrylic cement is going to be widely used in many different parts of the world. There is equally no doubt that its use by uninformed operator will produce a complication which might seriously threaten its reputation and might hold back the progress of the science which has happened today. And we have actually lost the forgotten art of the cemented hip orthoplasty. And I think it is our duty that we have to train our young surgeons, at least for the specific conditions, which will work it out. Pre-operative template is must, and still we are using the digital. We are using that templates which are available from the company. But just now, the Arun has showed the digital templating is much more versatile, and you can use it with multiple implant company. You don't have to wait it to one single company. So I think it's very important to have a pre-operative templating, and this is a Muller's idea that it at least allows the looking at the 3 dimension. It reduces the complication rate or inventory also. I think preoperative templating is absolutely must and mandatory for any of the hip, whether cemented or non-cemented, doesn't matter. It gives an idea of neck length cut. It gives an idea what is the stem size and what is the offset, cup size and limb length, what just was discussed by the previous surgeons. This one slide you have to keep in mind that how the cementing does the micro interlock. You can see the bone is just a honeycomb like that, and there's the cement going in. The fixation is achieved by penetration into the bone surface, that honeycomb bone surface. And this is called micro interlock mechanism. That's why you have the preparation of the bone is extremely important as far as the cemented hip orthoplasty is concerned. We need a micro interlock, and we want to preserve the possible bone for this. There are 10 commandments on acetabular side. You have to have a 360-degree circumferential exposure. Whatever approach you use, whether it is a Harding or posterior or DA, whatever you want to use, but the 360 degrees of exposure is absolute. You can't do a blind procedure, blind. The second is identify the true, where is the medial wall, because you got to get you got to take out the medial osteophyte, or you have to actually first reamer has to get into transverse deepening. Otherwise, you will land in a higher placement of the cup and not anatomical placement of the cup. So it's very important to find out the medial osteophyte, and that has to be reamed, and that's why you require first is a transverse reamer. Then you gradually enlarge till you get what we call initially called punctate bleeding at 3 flush signs, which Ranavat described. One is the ischium, other is the pubis, other is the ilium. But in cemented orthoplasty, you require a little more reaming because you want to expose the subchondral bone, because you want a micro interlock. So the hard subchondral bone has to be taken out. And this is one of the common mistake often by the many surgeons, that the roof, if you can see the roof preparation, that is a very, very sclerotic bone. You need to open that area. And there are special reamer. Unfortunately, they are not available in our country. And this was one of the striker company which has got a roof preparation, is a separate reamer which cuts the subchondral bone peripherally, and which allows the very good cementing especially in zone 1. Then you have multiple anchoring depending on the size of the acetabulum. You do multiple anchoring, usually about 8 to 10 millimeter deep, and do not actually violate the medial bone. Otherwise, you will land in perforation, and the cement might go inside the pelvis. So you have to be extremely careful for doing a multiple, and especially the ischium and pubis also has to be done. Then the other is the pulse lavage has done a great, one of the very good things that has happened, because this has improved the cementing technique. You can see before and after how the changes occur. This is another important thing we learned from Wrightington group, pressurization of the cement. Actually, the acetabulum is open mouth, and you try to pressurize the cement, some cement comes out, and it does not get a good pressurization. So that's why the people have started using what is called as a flange cup. So you can actually cut the flanges according to customize the acetabulum so that the mouth is closed, and then you can pressurize the cement inside. But this was the problem was the Chanley noticed that he was getting excellent cementing in the acetabulum, but he was not getting on the acetabular side. So the reason was it was a closed chamber and this was an open chamber. So they did a lot of experimental work as far as this is concerned, to get the pressurized in the acetabulum. And then the cup designs were changed. Actually Chanley what is called PIJ, pressure injection cup. And then it was modified to OGE cup by Wobleski. And today that is very, very commonly used, the flange cups are. And after that, everything, you have to remove the osteophytes to take out the impingement, which Arun has described the osteophytes, anterior, posterior, and other things are. So this is a very short video. You can see the 360-degree exposure. That is very, very important. You have to have at least 3 to 4 retractors all around. And that is the exposure you require. That is the first transverse reaming. You do it. and then you go on increasing, and then you put a trial cup and see that what is the size of the trial cup you should be able to move the trial cup into anteversion and as well as the inclination. Otherwise, you will get locked up and then you will have malalignment. You can see this is the OGE cup. We will cut according to the mouth of that acetabulum, so that the whole of the acetabulum. Then again, you do a trial with this after the cut, so that you are able to freely rotate and give some inclination. Otherwise, you have a malalignment. Then you measure the exact what is the size, so you can use the pressurization. And then this lavage makes quite a difference. And use the cement at the right consistency. That is the consistency where it doesn't stuck to the gloves. And this is one of the very important silastic pressurization. You will get only inferior cement comes out because there is an inferiorly deficient bone. It comes from the transverse acetabular ligament area. And then you put the cuff initially in that direction, and they change this and get a pressure. And after 2 or 3 minutes, you must take it out and use the pusher actually, because this holder does not give a pressure enough, and you should make complete containment of the acetabulum should be there.
Sir, the video did not play. Can you try playing it again? Video did not play.
Huh? Sorry.
Video play nahi hua video.
Video nahi play, sir.
Play nahi hua? Okay. Is this video playing?
No, sir.
Okay, we'll just go. What I'll do after that, I will get both the videos.
Okay, sir. Right.
Okay. So this is the statement from Ranawat. The state of the bone cement interface seen in early postoperative radiograph is a predictor of longevity of the cemented socket to the high degree of probability. If you see a day 1, there are no radiolucent line, there are 3 to 4 millimeter of cement around. This hip will last at least for 15 years plus. That is the prediction which Ranawat had. And you can see one of the example from Dr. Dholake unit. That is a post-op X-ray, and you can see the 19 years follow-up of that patient. And now it is getting almost more than 26 years. And that is the way the prediction is. So day 1, if you see a post-op X-ray, you should be able to predict your hip. And these are some of the examples, from my own hands. This is the way, normally we don't like to have a very thin cement mantle. As you see, the first X-ray is a little thinner cement, but you should have at least 3 to 4 millimeter. And if you look at the lateral X-ray, you see the anchoring holes, and that is your micro interlock. And you should not have any radiolucent line on day 1, and that cup will last for longer time. What about the stem side? There are again some 10 commandments. The basic, what is the design, which we just was talking to you by the Ravi. What is about intramedullary geometry? What is about the stem metallurgy, surface finish, and what is the OT temperature you should have? The canal flare index and the bone preparation are important, and broach and bis match. The broaches are on the higher side, that is 2 to 3 millimeters, so they can accommodate that amount of cement. So that's why it is called broach mismatch. And modern cementing usually is a hypotensive anesthesia. That is very, very important. Pulse lavage, retrograde cementing, air vent, pressurization, all that comes to on the modern cementing. And you should have a complete cement metal on AP and lateral in all 7 zones. So this is a basic design. There are 2 basic design. One is loaded taper, or called as a forced close. That was the design of exeter hip. That is all now today. Everybody follows that loaded taper. And composite beam was Chanley. That is a Chanley. Now today we don't follow the principle of Chanley closed beam. The second is intramedullary geometry. The taper, Chanley is a single taper. We like to use the double taper, that is exeter, and the triple taper is a C stem. Metallurgy today, there is no question. We have stopped using stainless steel. It is a cobalt chrome. It is a alloy, and it's a super alloy. And then the surface finish is all polished stems. We learned from the exeter group that polished stems are the best stems. What about the temperature of the header? 19 to 20 degrees should be there, which allows you allows you preparation time, working time, and final setting time. So that's why very, very important for as far as for the cements is concerned, the temperature of the theater should be maintained extremely well. The canal flare index, which I was just discussing, Ravi was talking, the type of B and C type, the door, we should have we can do a cemented. Do not use a cemented stem in canal A type. Reason is you have to ream the canal before you put the implant, and once you ream the canal, the cemented stem do not do well because you have lost a very cancellous bone, and which is important for micro lock, and that's why. This also we learned actually from our own patients, because initially we didn't have the uncemented about 30 or 40 years back. We reamed the canal, especially avian patient canal, and we had a high rate of loosening on that patients. So bone preservation and preparation is very, very important. We don't want to take out too much of bone, and the canal opening is absolutely important to get centralize the stem. Very, very important. The stem broach mismatch is 2 to 3 millimeter of envelope of the cement should be there. And modern cementing, I just told you. And cement metal has to be around so that you get what is called white out cement, which was described by Bill Harris. Once you have white out cement, the stem will sustain for at least 15 to 20 years. And I'll show you a couple of examples of that. This video is not running. I will run. Just see with this video is running. Okay, we'll run the video separately, both the videos. So survivorship of the cemented. If you look at these three graphs, there's early generation, which we know that is a failure at 20 years was around 75% or so. And then the second generation, we are better off. And today with modern cementing, you can look at that 20 years, about 85 and plus around 85 plus, around 90% of the stems are surviving as the cemented hips are concerned. And if this is the recent data coming from the American Joint Registry, that when primary THR or hemiorthoplasty was performed for the treatment of femoral neck fracture in 2023, cemented femoral stems were almost 56% were used in this case. So people are going in the elderly patient for fracture neck femur, for orthoplasty, as well as totally orthoplasty in elderly population with especially type C canal. There is an increase in the cemented stems, all across the registries. So these are some examples from Dr. K.T. Dholaka unit and our unit. So look at that 17 years follow-up in ankylosing spondylitis. That's 23 years, one of the Olympic player with a hybrid hip. And that's 35 years follow-up. And this is 38 and last is 44 years follow-up. That 44-year follow-up, both the side, the cup is worn and it was revised. Even in spite of trochanteric non-Indian, he had 44 years of good life of that hip. And that was the initial Charnley hip. We were not knowing, we didn't have a distal block, we didn't have any pressurization, we did not have a lavage. Still, the results of the stems were very good. And we did study at Bombay Hospital. This is doctors from Dr. Dholaka unit, 104 patients. We looked at it about almost 20 years back. I do not know after that what has happened. This was, we did that. And this is look at that graph of survivor. 84% of the stems survived at 20-25 years. We had a problem on the established side. The loosening rate was almost about 30, 35, 40%. But the reason was the poly was bad at that time. And that's 22 millimeter. The penetration wear was extremely high. And that was the reason the wear was much more on the established side. But stems have done fantastically well in spite of generation 1 cement technique. So these are some of the examples. My colleague, Dr. Vikram Shah's unit, I picked up a couple of cases. You can see this 21-year follow-up and 25 years follow-up of the cemented Charnley hip. There's hardly any wear also at that side. And this is one side was done by my boss, that is on the Charnley side. The opposite side was done by me, and my boss was definitely better. He had a magic hand. what people used to talk like a Robleski, that he can put the cement into a nutrient foramen. That is the amount of pressure and cementing he used to do it. And that is the result of the almost more than 40, 45 years. And that side is about 30 years, which I have done on opposite side, exeter stem. This was a great statement by Ranawat. The cemented orthoplasty should not be considered with using more than 32 head. Metal back sockets are out. You should not use rheumatoid patient. You should not use the cemented dysplastic socket, weak cancellous bone revision. I think if you can eliminate that, the cemented results can be much, much better. And this was a statement by Wobleski, that compression mold poly, highly cross poly should be used. Flange socketed pressurization technique, tapered femoral geometry, surface finish should be smooth or polished. Cement should be white out and not burnt out. Do not ream the canals, otherwise you will get burnt out. And preserve cancellous bone probably for the next revision to come. And that is a message. I'll go back to this and show you two videos. Go back, folder. Yeah, open that folder. बड़ा कर इधर नहीं ओपन है हाँ उसका फोन है नहीं अशोक झुंझुनू वाला है are you able to see?
No, sir.
Go back to your folder. Let's go open them. Can you?
Yes.
Yeah. That's your transverse, the reaming, and then you take a trial of different size, depends on the what is. You should be able to move this cup so that you can rotate, and as well as you can do the inclination. And this is the OGE cup with a trial there. So we'll have to cut this according to the exact mouth and customize actually the mouth area so that you can pressurize the cement extremely well. Then you also take the trial with after cutting so that it should not get locked up. You should be able to move that cup and give an inclination as well as. And that's a silastic pressurization. And then you will good lavage and use the cement in the right consistency. And this is one very important instrument of different size and silastic. So only cement comes out is only inferiorly. And that area is a deficient bony area. That's the reason that from the tail area, some cement comes out. And then you get first into this in the deep down, and then you do a proper inclination and give that pressure so that you get a lot of good cementing in zone 1. And then you take out the other part of the cement. But within 2 or 3 minutes, you should take it out because you can't Are you able to see? Hello?
Yes, now we can see.
Yeah. That's a box chisel as laterally. Open the canal, just keep a thumb on the medial side and try to get absolutely laterally. And that's your broach coming in. See the amount of bone preserved on the medial side and calcar side. And that's, I'm trying to get a little bit of antiversion what is required, maybe about 10 degrees or so. And that's my trial going in and give the reduce the and try to see the stability as far as this is concerned. Once you are the hip is fairly stable, then you can then measure the canal size actually. canal size. Depend on the canal size, then you have to use that restrictor. So exactly the length of the depth of the restrictor is depending on the stem size. Exactly, we do not want any cement in zone 4 because it's a taper slip phenomena. That is the lavage you do it so that you can open all the cancellous bone and then pack this with a ENT gauze. And this is retrograde cementing from distal to proximal. Then no cement comes out. Look at that, absolutely. And that's the way the retrograde. And this is very important pressurization. Most surgeons fail to do this, that you pressurize at least for a minute or so. And because your theater temperature should be good, so you should be able to pressurize gently, start actually using that gun. And
drug trade smothering? Sesame Street Crips?
There's nothing to say it isn't just boyfriend trouble.
Could be boyfriend trouble.
Bubbles coming out also in the area, the blood is coming out. That indicates a lot of pressure has been mounted by the cement. And now put the thumb on the medial side, and this every millimeter the stem has to go slowly. Don't hammer at all, and try to synchronize your thumb, pressurize the medial cement, and try to go extremely slow every millimeter to millimeter, and pressurize on the medial side. Don't allow any cement to try to come out on the medial side, and that will give a very good pressurization. And it take out this part of the usually the bond occurs, so you have to keep on there is another pressurizer. You keep it on the proximal trial till it gets hard enough, and that's the way you will have cementing on this. Any questions from the?
Sir, you said about the Chanley first slide. We heard that he was not allowing the surgeons unless they are trained.
Yes. The surgeons have to go to the writing turn, stay almost for a week or 10 days with him, and then he will show you the surgery. He will give you the 8mm film that time available. So you have to follow that. Second important thing that a lot of discussion, and he used to give a black book which contains from preoperative planning to the surgical CA. And he will see that there are facilities available, and then only you have to approach. There was a company called as Thakre's at Leeds, and then once he gives the certificate, then you can go and buy the implants and as well as take the set. Then only you are allowed to practice the Chanley procedure. He did wanted to disrepute his invention.
So would you consider some flexibility of version in the cemented step as an advantage?
Yeah, it is a great advantage in a difficult cases. Yes, that is a bailout always available for us. Definitely, there is no question.
Sir, how much your version you can adjust with the cemented stem?
The cement maximum is about 10 degrees or so, not much.
Suppose sometimes.
No, not like a SROM or Wagner. It is not that easy. About 5 to 10 days. But one important thing, retroversion stems, slightest retroversion is not accepted. Even not in 2 to 3 degrees also.
The reason for dislocation.
Yeah.
Dislocation is the reason.
Yes. Very high.
If there is excessive antiversion, have you seen, and there is a intowing of the.
Yes. If there is excessive intervention, it will anterior dislocate. So that's why we use Ranawat's combined antiversion test, which Arun was described. About 35 to 40 degrees in males and about 40 to 45 degrees female. We want female to be 5 to 10 degrees, slightly more antiversion than that.
Thank you, sir.
Thank you, sir.
Thank you.
Ashok is around?
Yeah, Ashok is there. Yeah, Ashok, you can share your screen, Ashok.
Yeah.
Okay, I think most of the principles around the hip have been spoken in almost all the talks. I think I have very little to say about it. So I'll just go through it. I'll finally show my video on uncemented total hip. I think any principles for total hip are divided into three. One is restoring biomechanics, that is to restore the center of rotation offsets and leg length as described by Arun. And then the fixation strategies, whether cemented, uncemented, or hybrid. I think Dr. Ravi has spoken about the stem part of it, and the bearing surface for your hip to run well, either based on whether you want to do a metal on poly, ceramic on or poly, or ceramic on ceramic. These are the basic principles of doing a total hip. And the basic principles of uncemented total hip are into two categories. That is, one, achieving a primary fixation at the time of surgery or immediately after surgery, so that you can make the patient walk or the component is pretty stable till your secondary fixation, that is the bone grows into these stems and cups and has a secondary fixation, thereby making the total hip, the uncemented total hip, totally viable and last for a much longer time. These are the basic principles. I think everybody has talked about templating. Yeah, this was the templating what I learned from Dr. Suri sir when I was with him in 2011-10, I think. And these are some of the templates what were done at that time in terms of femur, acetabulum on the pathological side, as well as then finally getting back into the pathology and what stems. So you're restoring the length, offset, as well as the center of rotation by templating. The same template what we use presently is on a robo. I think it is more versatile. You spend less time but more understanding with the robo. So the template, even with the robo, the whole planning is on the template. So templating is an essential part of doing any arthroplasty. Now, everybody wants the most important part of any hip replacement is positioning the cup right. There are three determinants. One is the depth, the height, and the angulation. I think Dr. Chanle wanted the cup to be more medialized so that the joint reaction forces are less, but doesn't work really well with the present scenario. What needs to be understood is the global offset, which includes the acetabular offset and the femoral offset. Femoral offset is fixed in most of the time. It is the acetabular offset what determines. So if you have a high offset, naturally high offset hip, then it's not good to medialize the cup. It is to keep it a little lateral than medialize. That is how one needs to understand about the acetabular offset. The other one is the height of the cup. One needs to be at the center of the cup. Your reaming is one thing which can, if you're not very careful, you can ream the cup much higher. So if you go higher up, then you're likely to have a higher joint reaction force. This will lead to loosening and then implant failure. So one needs to be within a centimeter of your center of the cup. So that will work much better. And finally, the angulation, which is very important. I think version and inclination are two important parts of putting a cup, and you want to keep them in antiversion of around 10 to 20 degrees and inclination of around 35 to 50 degrees. This will prevent dislocation. So I think in terms of femoral thing, you need to do a box cut so that your femur doesn't go into varus, so that you can lateralize it. Then you canal so that you go into the center of the canal. That is how you're going to do. And rasping is an important point. As with cemented, here also again you need to compact the cancellous bone. Do not remove it so that the cancellous bone can grow into your femoral stems which have a coating. So that is based on this. I'll go through a video. I'm not going to go through the whole video. I'm going to go through only the important part of it. I think the establer part. Give me a moment. Yeah. This is the positioning. I think I will go. So once the acetabulum 360 degrees of view of the acetabulum is done, this is how it is going to look at the true acetabulum in the falls. You need to ream vertically so that you get into the true floor of the acetabulum. And once you have done that, then you start increasingly serially your acetabular remus, but this has to be done at a correct inclination and version. And your final cup reamer catches both the anterior and the posterior part and gives you a catch. That is your final thing. And then you trial your cup. And once you trial your cup, most of the time, if it is a general hip, then you take trial as your landmark. Your anterior part, if you are going through posterior, is a little inside the cup anterior, and posterior is more prominent, and superior part is around 5 millimeters more exposed. So this is how it is going to be. And if you want to put your screws, I think that is the size, and this is the posterior part of it, and that is the point you want to put your screws. This is the cup what you need to put. Once you have trialed it, you put your original cup and you maintain your inclination and version. The artery over here gives me the correct version, and that's how you bang your cup, and you toggle it and rotate it to see how well fixed. So whole body is moving now, and it is bottomed in very well. So then you trial with your trial liners, or you can put your original liner if you're confident enough, and then you bang your liner, and you see that your liner is locked very well rather than being very loose. You have to cross check that. As I told, once your cup is done, you can go to the femur, you do a box cut to lateralize, and then you find the canal so that you are through the center of the femur. That's very important. And you start rasping so that the bone gets compacted in this case. And this is how we are going to compact or rasp. And finally, you know that your stem is not going, your proximal part reaches the saddle and your stem doesn't go beyond that. And there's a change in sound and fit. That is how it is decided. Then you trial it. And once you've trialed it, you look through the range of movement. You look for the combined anti-version, how it is. You do a stability test, and then you look for a range of movement. So I go to the hip to 90 degrees, then internally rotate, then you adduct it so that that's the sleeping position. It should not come out. And then you extend and adduct it and externally rotate so that it doesn't come out anteriorly. Then you measure your limb length. I use the bow stitch to call it. And finally, once you are happy, you bang in your uncemented stem. And once you are done that, it will change your sound and it won't go beyond that even if you back. And then you toggle it to see how well it is. And then you put your final head. Here it is a ceramic head which we have used, and then try to reduce it. Once it is reduced, it is well, you cross check again, and then you close your, this is a posterior approach. So I've used a Ranawat stitch to close the posterior capsule as well as the short external rotators. And then finally, I think once it is done, once the Ranawat stitch is done, I think then you close your wound. So thank you again. Done.
Thanks, Ashok, for an excellent demonstration of the uncemented hip. Any questions, please? Anybody can? Kiran?
Yeah, I think it was comprehensive. I've been answering the questions in the chat box.
Yes.
We have one I think is Vikram around? I think he must have left.
Yeah.
There's one question on cementing. Apart from 100% oxygenation, any other important steps to prevent BCIS? Is Pachori sir around? Any specific tips, sir?
I'm there. Yes,
Sir,
I'm there. Yeah.
Yeah, so cement syndrome.
Yes,
prevent-
yes. BCI, yes, it's a very, there's no question it happens. What we should do, patients you have to see there's a grade 3 ASA. Patient who have got cardiac abnormalities of ejection factor less than 20 to 30%. Patient who have got atrial septal defect. Are you able to hear? Kiran?
Yes, sir. Yes, sir. Yes, sir.
Yeah. Atrial septal defect. Patient who have got a COPD. These are the patients who are not good for cementing. Another thing, when the anesthetist has to be extremely careful for these elderly group of patients. IV fluid, at least those who have got a good cardiac status, they should have at least 1 liter of 1 to 1.5 liter of IV fluid before you start cementing. So they should have a CVP of 10 and above, which will reduce. Then those who are on the higher risk, all other technique of modern cementing you use it. Don't use a longer stems. Do not use a very heavy pressurization for this patient. Maintain the oxygenation, extreme, and the blood pressure both. Don't keep them on hypotension. The average pressure should be about 60 plus. The mean pressure is 60 or 70 plus. These are the things you have to keep in mind to avoid this problem of bone cement implant syndrome.
Right, sir. Thank you, sir.
Thank you, sir. And one more thing, sir, you can heat the stem. The one more thing to warm the stem.
Yes.
So the exiters do this. Warming the stem
and
so that the cement.
And don't use liquid cement. That's viscosity. Depends also that viscosity. And don't use too much of it. But other things you have to keep in mind. But the most important factor for these patients is anesthetist.
And other thing is to not. Other thing learn from you, sir, not to do the cementing hip in the late in the afternoon. Keep in the first case in the morning, not to dehydrate the patient. Yeah.
And your team has to be this is a teamwork. Because pre-operative, you have to identify this patient, pre-operative itself, intra-op, and there's actually WHO has produced a checklist for this. WHO has produced a checklist.
I think while cementing, I think one is the most important. People get scared and they just put in before it becomes doughy in a most liquid state. I think that is the dangerous time when you land up in problems.
Yep.
Yeah, before the
thanks for all the speakers.
Done for the I think it was quite exhaustive and very comprehensive thing.
Thanks, Ashok. Thanks, Kiran. Dhanshekar.
Thank you, Ashok. Thank you, KK.
Thanks a lot.
Thanks, Kiran. I think we'll take it up. Pachori, sir, thanks for this opportunity, sir.
Thank you, Kiran, Ashok, taking this academic activity on both of you on the shoulders. And next, you should announce what will be the dates and the topic we have.
Yes, sir. We'll come back in a few days' time. Thank you, sir.
2 days' time, sir. September 24th. Yes, thanks.